Welcome. My name is Bonnie Stabile. I'm the director of the Master in Public Policy program at George Mason's Schar School of Policy and Government, and also the editor, more pertinent to where our endeavor here, of World Medical and Health Policy Journal, which is sponsored by the Policy Studies Organization. And we're really pleased that they offered us this venue to talk about something that's really important to us, which is dealing with the crisis of addiction nationally that we are all confronting in various aspects, from health professionals, social work, every aspect of academia and clinicians and beyond. So at George Mason University, we've made a special effort to take on this issue, and it's the aspiration of George Mason as our strategic vision, as devised by Angel Cabrera, our president, which is to be of sort of practical use to the world. George Mason wants to we're not trying to be the ivory tower as much as we are to inform practical solutions to public problems, and that's very much at the heart of public policy and what we do at the Schar School. So to that end, to give you a little overview of what's happening with this panel, we have 3 speakers on this panel. Each will have 15 minutes, and I will cue them. I'm an aggressive timekeeper, so I'll let you know when you have sort of like 2 minutes left.
I've ignored meaner-looking people than you before.
You're on. So we want to have 15 minutes for each speaker so that we have time at the end to have discussion and questions. So we'll save all the questions, comments, unless it's a clarification comment, till the end so that we can have a group discussion bringing together the panel. So it's also our hope, World Medical and Health Policy, we want people beyond this room to be able to participate in this discussion and hear what we have to say. So we will have, as always, PSO offers on their website curricular materials, video online, and publications in World Medical and Health Policy. We're going to have a special issue of the journal in 2019 specifically about eradicating addiction. It's not an issue that's completely new to us. We have had a special issue on alcohol policy, and we've had a long-standing collaboration with Roosevelt University over the years doing a drug policy conference. And Katharine Harris is one of the presenters that I met there a number of years ago, who's an expert in this field, so I'm really glad that she was able to join us. So our first speaker is Dr. William Hazel, and he is the former Secretary of Health and Human Resources for the Commonwealth of Virginia. And he's joined George Mason University as a strategic advisor on health issues. Maybe you can tell us a little more about the specifics of that. But one of the endeavors that he's going to talk about is the effort to deal with opioids, the opioid crisis and addiction. So with that being said, I will pass the floor to you, and I'll start the clock.
Thank you, Bonnie, and good morning, all. My job is to frame the conversation a little bit today. I'm an orthopedic surgeon by training. I became the Secretary of Health and Human Resources in Virginia in 2010, and I served 8 years there. And my job as Secretary was to oversee a number of programs, including the Medicaid program, behavioral health and developmental services, health professions, the health department, and human services. And those were just 5 of the 11 programs that we oversaw. And during my time, I think the opioid epidemic became one of the signature issues that we were addressing. And a little background, the problem is not opioids. The drugs are changing. The problem is addiction, substance use disorder, if you will. The problem is behavioral health, and we are terrible as a society at addressing behavioral health issues. When we try to put it in the healthcare system is built on the concept that you come to me, you come to us, and we fix you, and then we send you back where you are. So we ask people who have perhaps the most difficulty motivationally, most difficulty rationally, often financially, to come most often for support. So we need to rethink this whole system as we know it. So I want to start here just by talking a little bit about what happened. And, most of you will recognize this as a map of the United States. This is 1999, and this is an overview of where the deaths were. And just as you go through this is 2004, and this is 2009. red is bad. And I remind everybody that that's not a political statement, it's a heat map, okay? But then this is 2014, and you can see opioid deaths overtaking everything. And the deaths are the tip of the iceberg, because it's about infectious diseases and opiate-exposed infants and kids coming into the foster care system and crime and people jailed and lost productivity at work and the human loss that goes with all that. So the deaths really don't begin to tell the whole story, but it does. This is a national map from CDC which showed the trends in opioids, and we saw this in Virginia. In 2012, we saw opioid-related overdoses overtaking gun violence and motor vehicle accidents as leading causes of avoidable death. And you can see from this, the substances change. And the reason I highlight the point that it's about a behavioral health issue and other things than the opioids is because we've had the natural occurring opioids, we've had synthetic opioids now, we're into fentanyl, and the truth is, in our areas of Virginia where we're seeing declines in opioid deaths, we're seeing increases in other substances that are causing overdose. And to show this, these are two 2016 maps, but they're still relevant. As you look at this from a policy framework, this is just Virginia, and I think it's indicative of the national picture. It's not the same every place. You know, people think about, oh, it's down in Appalachia. You know, Virginia is Virginia and then Appalachia. This area right here is west of Detroit. People in Virginia don't realize how far there's 7 state capitals closer to that place than Richmond is, the capital of Virginia. And here, the problem is prescription opioids. Other places, it's heroin. Depends on the distribution patterns, the availability of drugs. Fentanyl has come in. There's some places that seem to have all the good luck. And you can't forget benzodiazepines, another prescription med. Isn't it interesting, down here where prescription drugs are the problem? So we're looking at different problems. So when you're sitting here in the Capitol, or when you're sitting here in the Capitol, you have to realize we've got a whole set of different issues. Then cocaine has been on an upsurge since this map was made, and methamphetamine. Methamphetamine in Virginia came from Tennessee, where they learned to cook, and worked right up Interstate 81. Transportation corridors matter when we're dealing with this. When we go back to the other maps, this area has high heroin rates, comes from Baltimore. This area comes from Wilmington. This area comes up from Atlanta, so drug distribution networks become an issue as we're dealing with policy. And I mentioned it's not just about the deaths. This is a map, Fairfax County, one of the wealthiest counties in the United States. This is self-reported school data from high school students suggesting that they have used extensively prescription drugs in an unprescribed or an unauthorized use. And we also know from a state survey, or at least we have, that 2% of high school students will say they've tried heroin. 4% will say they've tried heroin, and 2% more than once. It's dramatic. The problem starts with pills, by and large. As we addressed pain in this country, I'm an orthopedic surgeon. By training, I learned that opioids were bad. And when you prescribe them, you use the smallest possible dose for the shortest amount of the time and the shortest acting substance. Then we got into this effort around being more compassionate, a noble cause. And we made pain management, or pain became the 5th vital signs. The vital signs are your pulse. You don't do well without a pulse. Your respiratory rate, you need a respiratory rate. Your blood pressure, you need a blood pressure. Your temperature has to be normal. But we made pain the 5th vital sign. So when you go to the emergency room and you get the smiley faces and you tell them you've got pain, we were expected to manage your pain. 0 pain became the goal. And when you're in the hospital in the middle of the night at 4 in the morning, when the nurse wakes you up because she has to and asks if you hurt, and you say, yeah, it is unlikely, ladies, that we're going to be able to send you to yoga. We have pills. We don't have those types of pain management tools. So we created a problem there. So the pills are out there, and if you look at where they're getting them, as people get started for misuse, it's from friends and relatives and so forth. So we have to understand the problem if we're going to address it policy-wise. there. The other thing to know policy-wise, it is a disease, and I don't think we knew that when I came through. But what we do know is that within about 48 hours of taking opioids, your brain begins to change. There are people who have alcohol issues, and you will hear them say, I knew the first time I took a drink, it was wonderful. We don't all respond the same to that, but the brain does change. And when the marketers came and said to us, oh, doctor, they won't get addicted when they take this for postoperative pain because it's not pleasurable, it had nothing to do with it. It was wrong then, it's wrong now, but what it is, it's a change in the brain. This is an idea, just an example of a healthy heart. This is a scan of metabolic activity. This is the diseased heart. No blood supply, no metabolic activity. This is a healthy brain. This is a diseased brain. This happens to be cocaine, but the same is true. The brain changes. And when the preacher from Eastern Shore stood in the back of the room and talked about what it does to the brain when people go from tolerant and habituated to addicted, it's that absolute craving. It makes you believe the devil has hijacked your brain. And you hear that. There is nothing that is driving people more than that. We have to recognize that. And we also have to recognize that abstinence and treatment are different. 28 days in jail reduces your tolerance. It's not treatment. And that's why when people come out, they're at high risk. So we developed a paradigm and a way to think about this, and one is just reducing the harm that it causes to individuals, families, communities, and so forth. As long as we have people, I think we will have people who have issues related to substances, and we have to think about the impact on others, the trauma on children, the other things that I've mentioned. We have to think about a paradigm around prevention. We have to think about treatment, what works and what doesn't, and how to supply it. We have to think about dealing with the bad guys, interdicting the criminal networks, because as long as there is a demand, however you fell into it, the bad guys will pick up if the supply goes away, and we've seen some of that. And then finally, and most importantly, I think we have to think about culture, which is less about policy and more about how we organize ourselves. So just very quickly to run through a few things. As we deal with this problem as a body politic, we have to think about what is the cost of doing nothing. Doing nothing is a decision. We always think about the decision is to do something, but the decision not to act is also doing something. And we truly don't know the human cost of this. We don't know all of the answers of economic cost, but we know it's there. And so as we look through it, we think about opioid-exposed infants. How do we get to mothers early, keep them engaged in services? We saw where services dropped off and children died because mothers relapsed. This is a chronic relapsing disease, and the best way we can look at it today. It's like a cancer that recurs over time. We don't deny treatment to those people if we can do anything about it. So we have to think about how we address the mothers. The family impact is manifest in youth trauma. As we look at the biggest causes of intergenerational poverty, it's intergenerational. And a lot of this has to do with the learning, the training that kids get and so forth. We have to think about how we build resilience and how we deal with those children. If you've heard of adverse childhood experiences, I think you'll hear a little bit more about social determinants of health. We know that children who have adverse childhood experiences will develop physical disease as well as emotional disease earlier in life than others. Non-physical trauma causes physical manifestations later in life. And we have to deal with that. The crime issues, forgeries, break-ins, supporting the habits, all are out there, and then what it does to the jails. And I could ask, who pays for that? And the answer is we all do. If I say who pays for that, it's the call and response part of the sermon. You say we all do. We have to manage that. The lost productivity in work. Can we think about recovery workplaces? Let's assume for a moment, as we did when HIV came and we took universal precautions, maybe we need to think about how we can get people back to work who have a history. Without a job, without a means to support yourself and your family, there is no hope, and you relapse, and all this cycle of harm continues. Who pays for that? We all do. And then we have this infectious disease, and there's evidence basis to show that we can do needle exchanges and things to reduce that. Controversial, but it's part of the package. Prevention is multifaceted. We know in Virginia that when we made formalized the CDC guidelines for prescribing at the state level through our boards of medicine, pharmacy, nursing, and veterinary medicine. We saw significant drops in the number of pills that were reaching the street. The downside of that is the individuals who happen to have this disease are not cured, and they will seek other sources, which means they go to the street where there is no FDA, which means that they're getting substances that change over time, doses change, and they're at risk for overdose and dying. But you have to get the pills off the street. There's no choice. We can look at medication disposal. Those went to the dentist, they gave me 50 pills, I only needed 2. What do I do with the other 48? Those pills are out there for kids to divert into their pill parties. We have to get rid of them. Naloxone availability, the recovery drug that keeps people alive until we can help them or until they're ready to be helped. That we've made that available. And then we have to think about the changes when there is an outbreak, 6, 7, 8 overdoses in an unusual pattern. How do we respond and get the data quickly across systems so that we can say something's changed? And then you don't tell the person who's drug seeking, you got to tell their friend, because the only text that they want is the one from their distributor, their supplier. We think about upstream issues. How do we get ahead of this? And this, I think, you're going to hear a little bit more about related to the trauma and the mental health and isolation, and then even misdiagnosis, depression, and pain management. These things get mixed up that we have to be better at. So these are all policy pieces. I'm going to run out of time, but initiating and maintaining recovery is there is a real dispute. Now, people believe that abstinence only versus medically assisted treatment, the key word of which is assist. We have to think in terms of that, but we do know that the recidivism rate, the rate of deaths in people who've had abstinence-only treatment is much greater than people who have the whole medically assisted treatment. You have to manage the cravings. We can't think of addiction as one disease with one treatment anymore. I think we'll find that there are different genetic bases, different environmental conditions, and we have to learn, and we do not know yet who needs what and for how long. That has to be a policy research piece of it. How we bring peers into the conversation. We've not been good at that in traditional medicine, but people who are credible to help you, I've been there, I can overcome this. The social supports, and then the system improvements. We've yet to really think about what's going to happen to this country if these people survive this acute crisis. And now we have thousands of people with the chronic relapsing disease who will show up at the police station or the jail before they show up in the medical system. How do we communicate? These are policy issues. I'm not going to spend much time on this. There'll be a speaker later, but we got to chase the bad guys. Where there's demand, they fill it. I encourage you to read the book Dreamland by Sam Quinone. It's a great book about this. And note that the networks, human trafficking, money laundering, are all intertwined, and we have to be talking to each other. And then the final thing, I would think, we had 300 people at a convening in Northern Virginia this year at Mason, and the big issue really is stigma. It impacts everything. We don't talk about this. That's the family secret. More and more it's becoming less stigmatizing, but unless we can address and talk honestly about it, unless we can talk about getting people help, unless we accept them back when they're in recovery from this disease, there is no hope, and that becomes a major problem. Even in the professional world, there are doctors who take care of patients, and there are doctors who take care of those people. As long as we think about those people, we won't solve this problem. Experimentation is dangerous. These kids that go to the pill parties, you bring in and you drop your pills in the bowl, and then you take a handful and you take them. The problem is polypharmacy today. The combination of things is as deadly as any one of the drugs. And then I think we do have to think about pain management. Zero pain is not the goal here. We know that other medications are as effective as narcotics in relieving pain, but if you came to me as a doctor and think the only thing that's going to work for you is opioids, you're probably right. We have to change that. That's a discussion we'll all have to have. So I hope this helps sort of think about the different categories that we have to fit our policy into. So thank you.
Speaker, Mr. Hazel, because I believe that he really is going to set the tone for our discussion. I'm an emergency room physician, so exactly what has been stated is true in terms of what I see in the ER. in terms of the different stages that people come in and the different addictions that certainly ebb and flow across the geography of the type of patients that I see. And I want to just mention and do a shout out to my co-presenter who just became a physician and actually has gone through the training that I'm going to talk a little bit about as a way of introduction, and then Dr. Williams is actually going to show how that works itself out experientially through the type of course that we have at Georgetown, but is being implemented across the country in medical schools to help sensitize physicians, starting with medical students and residents, but sensitizing them to look at this as part of the whole person as opposed to simply those people, as was mentioned earlier, but that we are those people, all of us collectively, because all it takes is one change in our life and we're confronting a lot of the issues that my patients and your families and friends see. In terms of what is service learning and how is it important when we're addressing this issue, I wanted to just show you a little bit about what is service learning in terms of its component parts. It deals with culture, as was mentioned in the previous presentation. Culture is a big piece, and unless we understand people from where they are in terms of their cultures, their beliefs, their backgrounds, their geography, their history, then we're sort of not even getting out of the gate. It is mission-based in that it is looking at what is service and what is our role as physicians, as healer, and as a provider in terms of the mission of healing and deriving wholeness to everyone who comes to us as essentially broken. And then experiential learning is the methodology with which service learning works through in terms of educating physicians to see people as part of a holistic community. Next. This is a little bit more of a breakdown in terms of what we are talking about in terms of defining service learning. It's within a social framework, not a disease or medical model. The social determinants of health, which was mentioned before, is the main structural component. And what do we mean by the social determinants? It's looking at all of those other elements outside of health as it relates to just biology. It would look at poverty, intergenerational poverty, occupation, education, health literacy, transportation, cities, the built environment, how they're framed. Those are all part of what the social determinants of health derives. And unless we as physicians, and as we're being taught in medical school, this sort of social framework, then again, we miss the key elements of change and seeing people within their brokenness and how they can be healed. Diversity, incorporating the human narrative, listening to the stories. Patients, even in the emergency department, can tell you their stories if you listen, even if you only have 2 to 3 minutes. And I always say that to my medical students. It's not necessarily what's the chief complaint, but what are they really here for? It's not just chest pain, it's not just belly pain, it's not just pain, period. But what are the underlying driving forces that are bringing them to the position of being in the ER, and for that matter, in any medical setting. And then the relationships that we build are crucial, and that's part of what service learning focuses on, building that relationship starting with the individual and then with the community at large. Looking at the social determinants of health, again, this is sort of a framework of the different elements that sort of feed as part of a system, neighborhoods and health, and what comprises those neighborhoods, what are the elements that are interfacing with health. And of course, we look at not just the structural aspects of neighborhoods, but we look at the behavioral elements that mediate in terms of stresses within the neighborhood. I was mentioned about the ACE, adverse childhood events. Those factor dramatically in terms of the development and decision-making, in terms of youth and development that carry through into adulthood as it relates to risk-taking and choices, which are very critical. And then neighborhood social environments, safety, social connectedness, institutions, and norms. When we look at service learning and where we can implement this educational piece, this at Georgetown is all of the different sites. You may not be able to see these from where you're sitting, but there's a variety of different, what we call community partner sites where where the medical students go and they interface with a whole variety of different patients. For example, they may go to Father McKenna Center, which is a homeless shelter, Arlington Street People's Assistant Network, My Sister's Place, which is a battered women's shelter. So all of these allow for different interactions and different opportunities for students to see. There's also Whitman Walker Clinic, Providence Hospital, where many of the students do HIV testing, and they learn about social determinants within the paradigm of HIV. Community mapping, again, links to this social determinant piece, where people are from. Place matters in terms of decision making. And students actually learn how to construct a map of what are the assets in their community, what are the faith-based institutions, how many libraries, how many schools are in where they live. Are there any hospitals, and if there's hospitals, are there any clinics or other healthcare centers, community health centers in those neighborhoods? Next. This is just the different pattern of the wards, and what some of you may or may not know is that east of the river, there's only one hospital, there's only a few health clinics. The distribution is mainly in the upper northeast and northwest sections of the city, and in fact, with recent developments at Providence, there'll now be no community hospital in Ward 5, which tremendously creates more of a health desert in that particular section. This is just some of the demographics in terms of Ward 5, predominantly African American, small number of health centers that are based for that particular population. Education, 72% high school, 22% bachelor's degree, unemployment rate, and poverty, which this is actually a much higher rate than what you see, 14% lower poverty rate compared to the DC average. It's higher than that. So I think at this point, framing this into how do we implement the tenets of service learning into an example. Marjorie's going to give us an example of a case that she had, a patient that she had in the emergency department, and discuss how she approached this patient and basically incorporated sort of the human elements and where were some of the breakpoints that we as physicians could have intervened and helped in terms of changing the ultimate outcome for this particular individual.
So as Dr. Bullock stated, I recently graduated from medical school, and as a medical student, you see tons of cases, specifically with opioid abuse. But one of the particular ones that stuck out to me was Miss J.O. She's a 23-year-old female that presented to the emergency department in an unconscious state. She didn't respond when someone called her name. She didn't respond when someone shook her vigorously. She didn't even respond to painful stimulation. Her story was that she was found on the floor of a grocery store bathroom by an innocent shopper bystander who then called 911. By the time she arrived at the emergency department, she was actively seizing. And I just remember being a medical student that several things conspired after that. There were several labs drawn, including urine. Eventually, her urine did come back from opioids, and unfortunately, when her respiratory rate and her breathing rate did not improve, the decision was made to intubate her and then send her to the intensive care unit. As a medical student, part of my job was to find out this patient's story. How did she come to the emergency room? What was her background? How did she get to this point today? And after searching through her medical records, I contacted her boyfriend, which then put me in contact with her father. And for the sake of time, once I became in contact with her father, I found out a couple of things about her. She was from a small town in South Carolina. She was an okay student up until the latter end of her high school years, where she started to, her grades started to slip. She started getting into a little bit more trouble. She started skipping school. And when I asked her father, you know, what was his point of intervention or what he felt was necessary to be done with his daughter when he finally found out that she was abusing heroin IV, he mentioned methadone maintenance therapy, which is a common treatment for opioid abuse, but he also mentioned that he was concerned about putting his daughter through a potential treatment plan that could be harmful to her. He didn't fully understand the background of methadone. He didn't fully understand its potential benefits, but he knew of the stigma around it, and he didn't want his daughter to be put in that situation. Unfortunately, he was brought to the hospital, and ultimately the decision was made to remove his daughter from life support, 23 years old. So as a medical student, I just remember asking myself several questions, specifically why didn't he be informed about other treatment options, and why did he not understand the benefits of methadone therapy? But more importantly, I asked myself, what was the physician's role in all of this? What was something that intervention early on could have happened? And I asked myself that several times, which is where service learning opportunity comes into play. So as a physician's role, identifying risk factors, asking patients, do they have opportunities for after-school programs? Or are there grocery stores? Is there a positive home environment? Or is there an environment where family members have been abusing, history of dependence or alcohol abuse or even opioid abuse? And really identifying those social determinants of health that really affect patients and their future outcomes.
This is just from Garfield Elementary School. I put this up because these are some of the tenets that we should, as physicians, include with all of our patients, providing comfort. When they give people lollipops, that's what elementary school students said. When they listen, listening skills. Say when something is going to hurt, be honest. When you can depend on them, being dependable. And making patients feel better when getting a shot or when they're scared, empathy. These are elements that we should be striving for. Next. I want to end with an African proverb that one of the students who had a similar encounter as Marjorie did in one of the outpatient clinics with a young lady who came in and was significantly addicted and then was transferred to the emergency department, and I saw her, and she was in quite a state of anger and had to be in 4-point restraints. And the student observing all this was quite frightened. When I saw him from afar, I thought he was a monster. When he got closer, I thought he was an animal. When he came even closer, I recognized that he was a human. When we were face to face, I realized that he was my brother. She began to see that the individuals that seemed so distant from her and were in such a state of confusion were actually the people that reflected herself. And that was probably the biggest lesson that she learned in taking the class. Thank you.
Hi, everyone. So I'm going to pivot a little bit from the medical side of things and talk about the intersection between addiction and the criminal justice system. So I'm in Houston, which is in Harris County, Texas, so the 4th largest city in the country, and I'm going to be talking about some of the research that I did with a colleague of mine at the Texas Criminal Justice Coalition. So the criminal justice population in Harris County, over 5,200 people are arrested, were arrested for drug possession in 2017. 58% of them were black. That's disproportionate. 19% of the population is black, so disproportionately affects minorities. Over 70% of those arrests were for a gram or less, so we're talking about primarily possession cases for personal use. Harris County has had the highest rate of admissions to the state jail in Texas for the past several years. So in Texas, other than marijuana, possession of any other drug is a felony. So you can get jail time with it pretty easily, and we have consistently been sending people to jail for that. The jail in Harris County is constantly right around capacity of about 9,400 people. They call it the largest mental health institution in the state of Texas, which is true. And the leaders in Harris County, they know there's a problem, right? We know that the jail is overcrowded. We know that we have this problem with racial disparities, and we're sending too many people to jail for drug use. So they're trying to address that, and what they did was they created what they've called a Reintegration Court. It's kind of like a drug court. It's supposed to sort of work faster. It essentially sends everybody that's been arrested for possession of 4 grams or less of any controlled substance to a court, where they are then offered the option of going through treatment versus being incarcerated. So far since the program started, about 3,200 people have undergone treatment through that court, and about 15% decline. So there's a percentage of the population that'll say, well, I don't want to deal with the requirements of the court, I'll just take my time served. So there have been more people that are getting diverted to treatment, but what are they being diverted to? What kinds of treatment are accessible for criminal justice involved populations? Is it meeting their needs? Is it affordable? Is it addressing all the kind of ancillary needs that they have in addition to drug use that also need to be addressed? And so those were some of the questions that we had, and that's why we started looking into this. So for our study, we talked to people in the criminal justice system to get an idea of what some of the challenges were with dealing with the drug offender population. We sent out a survey to community providers that deal with criminal justice involved individuals. And then we also did several follow-up interviews with providers in the community, and then again with criminal justice stakeholders. And we asked about a whole lot of things about treatment protocols and therapeutic approaches and types of insurance taken and the needs of the client base. I only have 15 minutes, so I'm just going to go over some of the issues that I think are most important. So one is the issue of residential treatment. So there's been a significant increase in demand for residential treatment in the past few years in the county, and that's possibly due to the fact that there is more of an effort on diverting people from the criminal justice system into treatment. But when you look, only about 31% of facilities that we surveyed offer residential treatment, and of those, 44% have 25 or fewer beds, and most of them are consistently at capacity or near it. So there's a real lack of availability in terms of physical beds for people who need that standard of drug treatment. Also, another thing that we found interesting was that for the providers that we surveyed, all of them either accepted Medicaid or received some sort of state funding, versus 56% that accepted private insurance. And I was a little surprised about that difference there. And I think one of the things, so there are a lot of providers actually that don't take private insurance, and they'll usually tell you it's because they don't want to deal with the hassle of the private insurers. Also, when it comes to residential treatment, there's a challenge in getting private insurance to cover that, because they usually want to cover the minimal amount of treatment available, which is like 30 days outpatient. So what this does is actually it kind of creates a gap for people who don't qualify for public funded treatment, but also maybe they have insurance, but their insurance doesn't cover it, or they have a really high out-of-pocket deductible that they can't cover, or they just can't cover the cost of it themselves. So there is sort of this middle gap in availability there. So treatment for co-occurring disorders. So an estimated 60 to 80% of criminal justice involved clients in the county are thought to have some sort of co-occurring mental health and substance use disorder. 69% of the providers that we spoke to said that they offer treatment for co-occurring disorders. But if you look, only 23% actually provide medications on site for psychiatric disorders. Now, I'm not saying that everybody that has a mental health disorder needs psychiatric medication, but when you're dealing with a criminal justice involved population, a lot of the times you do see people presenting with more serious issues like schizophrenia or bipolar, where medication could help. And the fact that only 23% can actually provide it on site means that they have to coordinate with another provider. People have to go physically to another place and get that medication, and it creates this additional step that can be really challenging for people. And then as far as insurance, you see, less than half accept Medicaid, only 28% take state-funded patients. So there's a gap there for the indigent population. And another thing, when we talk to people about this, one of the big challenges, obviously the lack of integrated services, which I think a lot of people are familiar with that problem. And in terms of, psychiatrists that treat mental health issues not wanting to treat the addiction, and addiction specialists not treating the mental health problem, but also the lack of continuity of care post-treatment. So if somebody is in drug treatment and it is determined that they need medication for a psychiatric disorder, once that treatment is completed, they might not have funding to continue on their medication. They might have to follow up with another doctor. It requires a whole lot of additional steps that often aren't followed through with. And then you get to a point where maybe somebody is off of their medication that was really stabilizing for them, and then that can increase the chances of not only relapse, but also, again, in the case of the criminal justice population, reoffending. So for opioid use, in Houston, opioids have not been as large a problem as they have been nationally. We have a lower than national rate of overdoses. We actually have a lot more problems with meth and cocaine, but opioids are still a problem, and a lot of people say that we're seeing an increasing a number of people that are overdosing from those drugs. So we looked at the provision for medication-assisted treatment. So we found that 17% of providers that will treat criminal justice-involved clients also offer MAT. Another 40% don't do it directly, but they'll coordinate with other providers for that treatment. 25% say that they don't treat patients for opioid use, and then another 15% say that they will treat opioid use, but they don't allow for medication-assisted treatment because they're abstinence-based facilities. So, you know, the availability of MAT could certainly be better there. And then one of the things that I thought was really interesting was, you know, talking to people. You know, there's this idea that in the criminal justice system that attitudes are changing, that there's increasing acceptability for MAT, and that, you know, judges and probation officers are more accepting of it. That said, I only found one clinic that consistently gets any kind of criminal justice referrals for clients, and it's all for Vivitrol. It's not for, which is a non-narcotic. It's not for the other possible medications. So I think that in some ways, like, we're paying lip service to this idea, we're getting there, but the access is still not where it needs to be. So systemic challenges. Again, we're talking about, you know, the criminal justice system as, you know, now it's trying to serve as this avenue to get people into drug treatment. And I think we're definitely in a better place than we were, you know, especially when we talk about a place like Texas where, you know, we have a high incarceration rate. There are efforts to change that. And yet, the thing that kept coming up was, again, that the criminal justice system is essentially ill-equipped to deal with a population that has addiction needs. The primary purpose of the criminal justice system is law enforcement and public safety, and those are not the same needs as treating people that have issues with addiction. The diversion court, the whole idea of diversion, again, it's better than jail, but what it does is it increases, it adds all these kind of, this layer of burdens on people that they have to meet. So they have to go to meetings with probation officers, they have to go and get drug tests, and in a county like Harris County is huge. It's the size of New Hampshire. Public transportation is not good. So if you live on the north side of town and your probation office is downtown, it's really hard to get there. So it creates a lot of additional requirements for people, and then even though you're talking about diversion, it's still something on their criminal record that then they have to go later and get expunged. And also the people within the county, like the probation that deals with trying to help people navigate the treatment system, they don't have a lot of good information on which places provide effective treatment, which places take which kinds of funding. The information is lacking, and that information is not shared with people who are then expected to just go. They're literally handed a list of places, of providers, and said, go find treatment on this list. And we combed through that list, and it is not up to date. There's places on it that are have changed their names, don't have working phone numbers, lost their state licenses. So it's a challenging kind of system. And then I'm running out of time, but just briefly, some of the recommendations. And these are, again, counties and Texas specific, but I think a lot of them can apply to other places. At the state level, you know, expanding Medicaid is one of the biggest things that the state could do to expand access to treatment, not just for criminal justice involved people, but for everybody. In Texas, it's a non-starter. It's not going to happen. You know, enforcing parity laws is another thing that would be a really big way to get people greater access to treatment, and increasing funding for treatment. I think that is something that actually might be doable with the legislature right now. There is interest in funding mental health and substance use treatment, so I think that there is a possibility for getting that. I think that there's some issues with the funding structures that need to be addressed. At the county level, you know, expanding integrated care services, creating like sort of one-stop shops. And again, I think these could be useful everywhere, but where people can get substance use treatment, you know, they can see somebody for mental health. They can also see somebody, maybe they need glasses, they need to get an eye exam, you know, see a regular physician. A lot of people need help navigating how to get social services or just a state ID card. So putting all that under one roof, I think, again, when you're talking about a county that's so spread out, I think this is really an important thing to do. Affordable housing, we know we need everywhere. And then I think from the criminal justice side of things, I think that it really makes sense. You know, there's a challenge where you want to protect public safety, and as far as that intersects with the problem of drug use, I think that the criminal justice system should focus its resources on dealing with the population that is most at risk of committing offenses that harm the public. So, you know, if we're talking about people that are committing assaults and that kind of thing, that population, I think, is where the criminal justice system should divert its resources. And when we're talking about a low-risk population, I think that there's other kinds of programs, like pre-arrest diversion programs. There's LEAD in Seattle, which diverts people away from the criminal justice system prior to arrest. So people don't even get involved in that. And I think that that is something that more counties should look at as a way of dealing with these different needs. And I'm out of time, so thank you.